This video is about patient who is on hemodialysis and who have history of diabetes. So this is a phenomenon. We always see that patients who had history of diabetes and ended up having end-stage renal disease, they seem to have their diabetes go away when they start hemodialysis, or even not go away. They take very little dose of insulin or very small dose of medication. So I wanted to talk about why that happens. There are several factors. Number one is that kidney normally clears insulin and failing kidneys do not. Healthy kidneys break down and remove insulin from the blood. In end-stage renal disease, insulin clearance drops sharply. Insulin stays in the bloodstream much longer. Even small insulin amount work more strongly. So the result is lower blood sugar, sometimes even hypoglycemia. And number two factor, dialysis improves insulin sensitivity. Uremia, which is a toxin buildup, causes insulin resistance. And hemodialysis removes uremic toxins, improves insulin receptor function, and enhances peripheral glucose uptake. And that results in better glucose control without medication. Number three is reduced hepatic gluconeogenesis. The liver makes less glucose in end-stage renal disease due to malnutrition, chronic inflammation, and altered hormonal signaling. So there's less endogenous glucose production, leading to lower fasting sugar. Number four, calorie intake often drops. Many dialysis patients have poor appetite, protein allergy, energy wasting, and weight loss. So they have less dietary glucose. That also lowers insulin demand. A1C becomes unreliable in end-stage liver disease because hemodialysis causes shortened red blood cells lifespan. There's a frequent transfusion, and there's an erythropoietin or epogen injection use. So hemoglobin A1C looks falsely low and may suggest diabetes reversal, but in fact it is not. Number six factor is the burnt out diabetes phenomenon. Okay, this well-described clinical state includes normoglycemia or hypoglycemia and no need for insulin or oral agents, and they are at risk of hypoglycemia. And it is associated with higher mortality, not recovery. So this is the point. Diabetes cured? No. Insulin resistance improved? Yes. Insulin clearance reduced? Yes. A1C reliable? No. Hypoglycemia risk? Very, very high. So best monitoring strategy for dialysis patient is pre-dialysis and post-dialysis glucose checks and occasional fructosamine testing instead of A1C, and conservative insulin dosing because of risk of hypoglycemia, and avoiding glipizide, glyburide. And also watch the patient for hypoglycemia on the day of dialysis. So bottom line is diabetes does not disappear in ESRD, it goes silent. Pancreas is not healed, the metabolic environment has changed. If the kidney function improves, for example, in renal transplant patient, diabetes often returns aggressively. So thank you for watching.